Hi, my name's Amanda Chaney, and I'm a nurse practitioner. I work at Cleveland Clinic in Florida, and I'm Senior Director of Advanced Practice Services. Today, I'm going to talk to you about what primary care clinicians need to know about MASLD and MASH. Sponsorship and support. This presentation is sponsored by Illinois Academy of Family Physicians and Primary Care Education Consortium, and sponsored by an additional education grant from Novo Nordisk Incorporated. In collaboration with PCMG, Primary Care Metabolic Group. Join at www.pcmg/us.org for free CME discounts on conferences and resources for clinicians interested in metabolic disorders. CME and CME information. The AAFP has reviewed what primary care clinicians need to know about MASLD and MASH and deemed it to be acceptable for AAFP credit. The term of approval is from 7/1/2024 to 6/30/2025. Physicians should claim only the credit commensurate with the extent of their participation of the activity. Following this CME activity, participants will have the opportunity to earn an additional 2 prescribed credits for participation in each translation to practice exercise. Information on translation to practice will be shared within the activity. If you want translation to practice credit, you may qualify for an additional 2 credits if you make a commitment to change your practice behaviors in your post-presentation survey. In that survey, you will be asked to commit to changes in your practice behaviors, to specify what those changes are, and to provide your name and email address. If you do not enter the required data mentioned above, you will not be eligible for T2P credit, so please include all of the information. Approximately 6 weeks later, we will contact you asking if those changes were made, along with some additional questions. If you have completed those changes, you will be eligible to complete the survey and generate a certificate for the additional credits. CE information for NPs. The American Association of Nurse Practitioners Certification Program and the American Nurses Credentialing Center accept AAFP prescribed Category 1 credits. Faculty disclosure information. Primary Care Education Consortium adheres to the conflict of interest policy of ACCME and the AMA. It is a policy of PCEC to ensure balance, independence, objectivity, and scientific rigor in all of its education activities. All individuals in a position to control the content in our programs are expected to disclose any relationships that they may have with commercial companies whose products and services that may be mentioned by the participants so that they may evaluate objectivity of the presentations. In addition, any discussion of off-label, experimental, or investigational use of drugs or devices will be disclosed by the faculty. Only those participants who have no conflict of interest or who agree to an identified mitigation process prior to their participation were involved in the CME activity. As far as disclosures, I do not have any disclosures to report. Austin Ulrich, medical writer, and Michael Hannock, reviewer, have no disclosures to report. So here are our learning objectives for this presentation. We want the participants in this presentation to be able to apply evidence-based strategies for identifying and stratifying risk in patients at high risk for MASH. Formulate strategies for diagnosing, staging, and monitoring MASLD or MASH with non-invasive tests and biomarkers. We want you to know how to implement current treatment strategies and care pathways in managing MASLD and MASH and underlying metabolic diseases. And finally, we want you to be able to initiate appropriately referrals to specialists for patients with high-risk disease, including MASH, as appropriate. So here's a little introduction into MASLD and MASH. These terms are fairly new. About a year ago, they converted from the old terms, which were NAFLD and NASH, which stood for non-alcoholic fatty liver disease, and NASH, which was non-alcoholic steatohepatitis. The new terms now really have just changed that first letter and changed it to M, but the significance of this is really important. It is now, instead of NAFLD, it's MASLD, which is metabolic dysfunction associated fatty liver disease, and MASH, which is metabolic dysfunction associated fatty liver disease, or steatohepatitis. This with the SH. So with that rationale, we wanted to make sure that our patients and our providers understood that it isn't necessarily just the absence of alcohol that is why this patient has fatty liver disease, but it is truly a myriad of metabolic disorders that are complementing each other to cause issues in the liver. All of it impacts to having more fat in the liver cells. Steatohepatitis is a very important aspect of the disease and a main driver to progression of disease and how bad that liver disease can become. How prevalent is it? Well, MASLD is estimated to affect 30% of our adult population worldwide. The prevalence of MASLD has increased from 22% to 37% just from 1991 to 2019. The burden of MASLD and its complications is expected to continue increasing in the coming years. And increasing MASLD prevalence parallels with increases in obesity and obesity-related diseases. MASH has been found in up to 63% of patients with MASLD who have undergone a liver biopsy. MASH is less common in patients with MASLD without an indication for liver biopsy, about 7% of patients. And MASH is one of the leading causes of adult liver transplantation in the United States. I was a nurse practitioner in liver transplant for about 20 years prior to coming to this role now. And at that time, the main cause for liver transplant was hepatitis C. Now we have amazing medications that cure hepatitis C. And the prediction at that time was that MASH was very quickly going to become that #1 top for liver transplantation. And it is coming to fruition that that is going to be true. When we think about development and progression of MASLD, initially we have fat in the liver cells. It is irritated by that, and so inflammation can occur. That inflammation causes the liver to have injury. The liver as a whole turns a little bit more greasy. So that just kind of signifies the top picture of the liver with the second picture. So it's gone from a healthy looking liver to this more greasy, loose kind of appearance, yellowish appearance. And over time, if factors aren't reversed, if metabolic issues that have been gone on, like ongoing uncontrolled diabetes or hypertension or high cholesterol, if those factors aren't corrected, then the patient can progress to more inflammation. And we all know what happens when there's inflammation in the body. It causes damage. It causes scar tissue. And that scar tissue is called fibrosis. Fibrosis can reverse itself. The liver is the only organ in the body that can repair the damage that's done. However, it can only do that to a certain point. So once the fibrosis gets to stage 4, it is no longer reversible, and that person has moved into the state of liver cirrhosis. And at that time, the only cure for liver cirrhosis is going to be a liver transplant. So now we're going to talk a little bit about the clinical burden of MASLD and MASH. It is associated with severe complications such as cardiovascular disease and end-stage liver disease. Cardiovascular disease is a leading cause of mortality in patients with MASLD. It is widely underdiagnosed. Many times patients have no idea that they have any degree of fatty liver disease until something happens. So the most common scenario that I see in my clinic is that a patient has abnormal LFTs or they have abdominal pain, An ultrasound is done, and on the ultrasound, it shows fatty liver disease. And then we do the whole workup about fatty liver disease. So I would estimate, and I totally agree with this statement, that it is majorly underdiagnosed in our nation and probably worldwide. The asymptomatic presentation occurs until cirrhosis or hepatic decompensation is present. So that means if patients start developing ascites or fluid retention issues or have an episode of throwing up blood and GI bleeding, those are the things that present itself, and then the patient is like, why is this happening? And it's because they have cirrhosis and they never knew they had it. So saying that, of course, it is really important for earlier diagnosis and identification to occur to reduce the burden of disease. Earlier intervention can reduce the progression of disease and address to the contributing comorbid conditions. This is a slide looking at a comparison of the risk of severe liver disease with the liver-related mortality. So if we look at those fibrosis stages, fibrosis stage F0, F1, those are early stage fibrosis. F2 and F3 are getting worse, but those are still times where it's reversible. And then F4, you can see it really jumps up there to the severity of liver disease at that point. Similarly to the chart on the right, you can see that as the fibrosis stage increases, the liver-related mortality increases with quite a large jump at that F4 stage. So what do patients think about this? Well, approximately 89% of patients with MASH report that their comorbidities have an impact on the severity of their disease, which is good because sometimes the patients that I see in clinic have very little insight into what is causing their fatty liver disease. About 40% of patients feel that successful management of MASH would improve their symptoms. Patients with MASLD and MASH may be perceived as asymptomatic conditions. I had one patient in clinic a few weeks ago who told me that she was told she had fatty liver disease about 5 years ago and that it was no big deal by her clinician. And then now I'm seeing her and she has cirrhosis. So she was very upset that, 5 years ago she could have done more than what she did because she didn't think it was a big deal, and now she has cirrhosis and she's dealing with those complications of cirrhosis. So it really is important to not just state that it's not a big deal. It is a big deal, and there are things that we can do to help these patients. Multiple studies have shown that patients with MASH have a poor quality of life. Patients may experience non-specific symptoms like fatigue or abdominal pain, and MASH is associated many times with dyslipidemia, hypertension, and diabetes type 2. It is really important to have a multidisciplinary approach when caring for patients with MASLD and MASH. Dr. Jarahan had said at this point, a collaborative approach to MASH and liver disease care has the potential to positively affect MASH progression and the deleterious complications that can impart to patients and their families. In other words, when we have a team approach to this disease and for these patients, we can avoid many times complications of cirrhosis, which can just be extremely traumatic to patients and to families. But the team approach is really beneficial and able to do this. So what does that look like? This is an example of an integrated multidisciplinary clinic for MASH and MASLD. So we'll start here at the top center with the consultation. At the consultation, the provider will look and see what the severity of illness is, get some blood work, look at some more imaging studies, and then go through and figure out what are those diagnoses, whether the patient has diabetes, does the patient have hyperlipidemia, and then look at treatment. What treatment options are there? Typically, our treatment for MASH and MASLD have always been diet and exercise. We have not had any medication up until this year that have been able to target fibrosis stage 2, stage 3 with a patient with MASH. So there is pharmacotherapy coming for specifically this case, but historically we haven't had that option. And so our rule of thumb has been diet and exercise, diet and exercise. And that's been really frustrating for our patients because they know that they've tried 6 months to lose a pound and they haven't, and so they get frustrated that the work that they're doing isn't being recognized and isn't making an impact. As far as the pharmacotherapy on this slide, in my mind, that goes to better management of uncontrolled diabetes if that's present, or if they have hyperlipidemia, putting them on a statin to control those other factors that have a huge impact on this disease. So what is the primary care clinician's role? Non-hepatology clinicians are needed to handle the anticipated burden of MASH-related advanced liver disease. And we do expect that these consults are going to be coming fast and furious as our population continues to age and as the obesity epidemic continues in our country. Patients with less severe MASLD symptoms and disease are best managed in primary care. So the potential roles of PCCs for identification and management of MASLD and MASH are screening, diagnosis, and risk stratification. The second piece would be treatment of less severe disease. And lastly, when to refer to a specialist. Patient and PCC survey on MASLD and MASH. There was a cross-sectional study on the diagnosis and treatment of MASLD and MASH in primary care. Interestingly, 72% of patients had initial discussions about their symptoms with a PCP, but only 30% of patients actually received a diagnosis of MASH. Patients saw an average of 1.7 healthcare professionals for their symptoms. Most, or 65%, saw a PCP for fatty liver disease. In the survey, PCCs noted that they personally diagnosed most patients with MASH in the primary care setting. About 1/3 of patients are referred to other healthcare professionals for diagnosis. So now we're going to go into a patient case scenario. This patient is a 57-year-old woman with type 2 diabetes and obesity, and she presents to established care at a new primary care clinic. She notes that she is concerned about dying from heart disease because that is what happened to her parents. She consumes 5 to 6 alcoholic beverages per week. Her medical history includes diabetes for 12 years, obesity, hypothyroidism, osteoporosis, and hypertension. Her labs show that she has a hemoglobin A1C of 8.7, fasting triglycerides of 200, and a fasting glucose of 140. Her medications include metformin, glyphoside, insulin, lisinopril, hydrochlorothiazide, levothyroxine, and alendronate. What indicates the patient should be screened for MASH or MASLD? And what needs to be addressed for her related comorbidities? So next we're going to go into screening, diagnosis, and risk stratification. So how do we identify patients at risk with MASLD or MASH? The patients at greatest risks are the ones that are going to benefit most from screening. Patients who are overweight or who are obese, patients with type 2 diabetes or prediabetes, patients with one or more of the following metabolic dysregulation, including central adiposity, insulin resistance, obstructive sleep apnea, triglycerides that are greater than 150, HDL that is less than 50 for men or less than 40 for women, blood pressure greater than or equal to 130/85, and patients with a family history of MASLD. What is our MASLD diagnostic criteria? It's defined as hepatic steatosis detected by imaging or biopsy, plus at least one of the 5 characteristics. Number 1, BMI greater than or equal to 25, or waist circumference of greater than 94 centimeters in men and 80 centimeters in women, or ethnically adjusted. Fasting serum glucose of greater than or equal to 100, or a 2-hour post-load glucose level of greater than 140, or a hemoglobin A1C of greater than or equal to 5.7, or receiving anti-hyperglycemic drug treatment. Blood pressure of greater than or equal to 130/85, or on treatment for hypertension. Plasma triglycerides of greater than or equal to 150, or on drug treatment. And then 5, plasma HDL cholesterol levels of less than 40 for men or less than 50 for women, or again on specific drug treatment. There's a few non-invasive testing approaches that are out there. However, liver biopsy is the gold standard to diagnose and stage severity of liver fibrosis. But speaking as someone from that specialty in hepatology, we do not really do a liver biopsy in these cases of MASH or MASLD to figure out if they have fatty liver disease. Usually the liver biopsy is preserved for other circumstances. We do have non-invasive testing, and we're going to go through a couple of those. The most common one is called the Fibrosis 4 Index score, and a score of less than 1.3 may be useful for excluding advanced hepatic fibrosis in patients with MASLD. Additional testing or liver stiffness or biomarkers for risk stratification should be done if the FIB4 score is greater than 1.3. Patients with results suggesting advanced liver fibrosis or cirrhosis should be monitored with elastography. Clinical practice guidelines recommend stratifying risk in patients with MASLD using non-invasive testing, limiting patients who are referred to specialists to those who are at high risk for advanced liver disease. This is an interesting slide showing the MR elastography and biopsy results for early fibrosis all the way up to the level of cirrhosis. And you can see how the changes are pretty significant as you get from this early stage to F2, F3, and then into F4. So when we talk about risk stratification, the Fibrosis 4 index is useful as an initial test to screen for advanced liver fibrosis. It has a high negative predictive value. It's reliable at excluding advanced fibrosis if the score is less than 1.3. It has suboptimal positive predictive value. So for patients with an elevated Fibrosis 4 score, so again, greater than 1.3, we would want to understand how stiff the liver is and do this liver stiffness measurement. This can help identify compensated advanced chronic liver disease and clinically significant portal hypertension. Liver biopsy or elastography is considered for patients with indeterminate or discordant non-invasive test results, and then based on the risk, monitor with non-invasive testing, referral for elastography or liver biopsy, or referral to a specialist would be recommended for further workup and management. Non-invasive tests can be used for risk stratification in the diagnostic evaluation of MASLD, and this is really important to understand for our primary care audience. So here's a simple algorithm looking at that non-invasive testing of MASLD and MASH. So we have the FIB4 index or Fibrosis 4 index here. Again, if it's less than 1.3, this patient is unlikely to have advanced liver fibrosis. However, if it's greater than or equal to 1.3, that pulls the trigger to look at the liver stiffness measurement, and usually that's done by elastography. If the result is less than 10, we can exclude advanced liver disease at that point. Here's another algorithm for non-invasive testing of MASH and MASLD. If we look at the first column, this is the elastography results and how high those results are, or the increased stiffness. In the second column, we have whether or not we have clinically significant advanced liver disease or not. We, on the third column, look at what we're going to do about it. So in this first higher color column, we're thinking about it requires monitoring. We're going to repeat this testing in 1 year, and then if it's ongoing or worse, then we would refer to a specialist. In the second row, we consider HCC surveillance because at this point, this patient probably has advanced fibrosis or cirrhosis even, and those are the patients that we would want to send for HCC or hepatocellular carcinoma surveillance, and again, refer to a specialist. In the third row, we definitely, for these patients, want to refer them to specialist care because we're assuming that they have some significant portal hypertension and need the care of a hepatologist or even referral to a transplant center. Treatment of MASLD, MASH, and metabolic comorbidities in primary care. So we're going to review a few practice guidelines. These guidelines are for the AGA. The AGA clinical care pathway emphasizes several steps for identifying, diagnosing, and managing MASLD. The first part is to identify the patients at risk. Who are those individuals? We want to obtain history and laboratory test. We want to conduct non-invasive testing, such as the FIB-4 score. And if it is greater or equal to 1.3, then we would conduct the LSM, or the stiffness measurement. We would initiate treatment or referral based on risk. So the patients are at low risk. We can repeat these non-invasive tests in 2 to 3 years unless clinical circumstances change, which can happen. If there's indeterminate risk, we would refer to hepatology or do a liver biopsy or MR elastography or monitor for reevaluation in 2 to 3 years. If they're at high risk, we definitely want to go ahead and send that referral to a liver specialist. The practice guidelines for AASLD and AACE are very similar. They do add an additional pieces of information, so we'll go through that. Patients with MASLD who are overweight or obese should be prescribed a diet that leads to a caloric deficit. Diets with limited carbohydrates, saturated fat, and enriched with high fiber and unsaturated fats. Many times in clinical practice, we'll recommend the Mediterranean diet. That's a fairly easy one to, well publicized and easy to get information on that of how to pursue that sort of diet. Patients with MASLD should be strongly encouraged to increase their activity to the extent possible. We typically tell patients about 30 minutes of activity every day, but as you know, that is doable for some patients and it is not doable for others. And so just encouraging them to do what they can and start there, and doing it on a regular basis will build up that endurance. Bariatric surgery should be considered as a therapeutic option in patients who meet criteria for metabolic weight loss surgery. Drugs approved to treat associated comorbidities with potential benefit in MASLD may be considered in the appropriate clinical setting. Semaglutide can be considered for its approved indications in patients with MASH, as it confers a cardiovascular benefit and improves MASH. And pioglitazone improves MASH and can be considered for patients with MASH in the context of patients with type 2 diabetes. However, neither of these is recommended purely as a treatment for MASH, and that's a really important designation to understand. When we look at the EASL, or European guidelines, this was published in June 2024. Some additional pieces that they wanted to note: dietary and behavior therapy-induced weight loss should be recommended to improve liver injury. And this is, again, kind of verbatim of what all the clinical guidelines say, that the dietary, exercise, clinical weight loss improves the liver injury. In adults with MASLD and who are overweight, weight loss should aim at sustained reduction of greater than 5% to reduce liver fat, 7 to 10% to improve liver inflammation, and greater than 10% to improve fibrosis. Adults with non-cirrhotic MASH with significant liver fibrosis greater than stage 2 should be considered for treatment with resmetirom as a MASH-targeted therapy. Treatment with resmetirom may be considered for individuals with MASLD without cirrhosis who have advanced fibrosis, are at risk for steatohepatitis with significant fibrosis, or risk of adverse liver-related outcomes. GLP-1s, pioglitazone are safe in use with MASH and should be used for their indications. SGLT2 inhibitors and metformin are safe in MASLD and should be used for their indications. In adults with non-cirrhotic MASLD who have an approved indication, bariatric surgery should be considered. Next, we're going to talk a little bit about lifestyle interventions. There are so many cases where patients have been told that they need to make lifestyle interventions, make lifestyle changes, and they come to me frustrated that they've tried everything under the sun to lose weight, to walk, to be better in their overall health, and they are very frustrated that the weight on the scale hasn't moved. I think we really have to go a little bit deeper with our patients when we tell them lifestyle interventions as a treatment option for MASH and MASLD. One thing that has helped for me is to write out what exactly is 5% of their weight loss compared to where they are now. What would 10% be? And that gives them a number in mind. It gives them a goal to shoot for. So when I see them again in 3 months, we can talk about it, and we can talk about whether they made any move in that direction or if they made the move in the other way. And I like to see them back sooner rather than later, because if they move in the other way and they're embarrassed, I can talk them through that and tell them that it's okay. We all go through this. We all are, in this together. And just making sure that they understand, if as long as you're eating fruits and vegetables, more lean protein, you're following all these very specific examples that I'm giving you, I don't care if you gained a pound. The fact that you've gotten rid of all of your sugary drinks, you're drinking less sweet tea, you are drinking more water, all of those are huge wins to me. So I really like to plot it out for them of all the good things and all the bad, and typically they'll realize they're doing a lot more good for their bodies than they are bad. And I think it's really important. I know we're all busy in our clinic practices, and it's really hard to take that ton of time with patients, but I have found time and time again that works really well. It drives home the point that they do have some control in this, and people tend to do better when they believe that it's in their control to make those impacts. All of the things I mentioned, more fruits and vegetables, more lean sources of protein, that is really emphasized not only for liver health, but also for cardiovascular health, which is where these patients are. So many of their metabolic diseases are impacting their heart as well. So teaching them those sorts of dietary changes is really important. I tell my patients not to put any additional salt on their food. Try to take away the salt shaker. I know that's kind of mean, but it's so important because when patients do have more advanced stages of liver disease, that salt does much more detrimental effects to their body with fluid retention issues than they really care to realize. So giving them a goal, making sure they understand even that 5% weight loss is going to do a huge amount of health for your liver and for your heart. You might not be able to see it too much on the outside, but you have to know that it does do something. And then as far as the physical activity recommendations, I have many patients who are debilitated. They as I have said before, they can't go down to the driveway to get the mail without being out of breath. And so it's really important to meet them where they're at, maybe send a consult to physical therapy so that they can meet them where they are and do an evaluation to see what is possible and what's not. Maybe it's just doing some resistance bands while they're watching their favorite show in the evening, or maybe it is walking to the mailbox and back and going for a second walk and back during the day. Um, the ideal goal is to have this 30 minutes a day of moderately intensity exercise each week. So to total around 150 minutes per week. But again, some patients just can't do that, and that's unreasonable. And you tell them that, and they feel hopeless. So again, I think it's really important as primary care providers, as specialists, to really understand what is realistic in the situation that you're in and make sure that they have the opportunity to respond to that and partner with them on that plan. Understanding, like, do you have any ethnic sort of dietary requirements that maybe I'm not thinking of, but it's very important for you. Making sure that those things are taken into consideration too, so that we can come up together with the best plan to make these lifestyle interventions reasonable and sustainable. Again, looking at the weight loss impact on MASH and MASLD, there's been several articles that have talked about this, that weight reduction is associated with improvements in MASLD and MASH. And the greater the weight loss yields the greatest benefit on the liver symptoms. So even with just a 3% weight loss, steatosis is improved. With 5%, the ballooning and inflammation improves. With 7%, MASH has been seen to resolve. And then in greater than 10%, fibrosis reduction occurs. So really encouraging and awesome news that I tell my patients frequently to give them hope that it really does work and improve their liver health. So here are some pharmacology considerations. Historically, as I mentioned earlier, there were no approved MASLD or MASH pharmacotherapeutic agents for many, many years. Pulgadazone and GLP-1s have demonstrated efficacy in reversing MASH, although they weren't FDA approved for MASH. And then SGLT2 inhibitors have also been recommended as adjunctive agents. We now have resmetirom, and it's currently the only pharmacologic agent approved for treating either MASLD or MASH, and it was just approved this year in March of 2024. The phase 3 study, the Maestro-NASH study, looked at patients with biopsy-confirmed MASH and a fibrosis stage of F1B or F2 or F3. Those taking this medication experienced improved liver outcomes compared to those who received placebo. They noted significantly higher rates of MASH resolution and improvement in liver fibrosis by at least one stage. And again, it's important to note that the other medications that historically we have been used as adjunctive therapies to help MASH are not FDA approved to treat MASH. And we've been through this for years. There have been so many agents that have been studied to treat MASLD and MASH, and some have shown some efficacy, and some just have been taken off the table altogether. But you can see that this song and dance has been going on for many, many years. And so to have this one that is FDA approved this year is extremely exciting for our patients who have early F2, F3 graded fibrosis, and know that this is something that we can offer them to help them. There's some MASH and MASLD data for agents approved for other conditions. The semaglutide has been out there for a while, looking for patients with MASH, F1, F2, F3 fibrosis, and then MASH without cirrhosis. Results have shown significantly higher percentage of MASH resolution and improvement in transaminases, but again, not FDA approved for that yet. We have another one from the LEAN-3 study for patients who are overweight and clinical evidence of MASH. Again, showed significantly higher percentage of MASH resolution. We have several diabetes medications that are out there, significant in the decrease in MASH biomarkers and increase in apopoietin, which has a relationship with fat production. So in managing comorbidities, treatment recommendations for patients with metabolic comorbidities and MASH and MASLD are focused on addressing those metabolic problems that we've discussed before. So we want to specifically look at the cardiometabolic risk factors, so the glycemia, the blood pressure, lipids, and body weight. For the steatohepatitis, which all that means is fat in the liver cells and inflammation because of that, especially with clinically significant fibrosis. So that would be stage F2 to F4. Initiating pharmacologic therapy to address comorbidities and MASH and MASLD can be based on non-invasive testing. So we know if we have an elevated FIB-4 score, which is greater than 1.3, elevated serum transaminases, imaging when we do transient elastography or MR elastography, and then plasma biomarkers for fibrosis. We'll take this piece by piece. So first, looking at hypercholesterolemia, the recommended target is to have the intermediate risk less than 100. Higher risk, patients who have diabetes or other cardiovascular risk factors, we want those patients to be less than 70. And then the highest risk, we want those patients to be less than 55. So the first line agent is to give them a statin at the appropriate dose and intensity. There are many rumors out there that if a patient has liver disease, you do not want to give them a statin. But particularly in the case of a patient with MASLD and MASH, you do want to give them a statin because that is what is going to treat the MASH and the MASLD and have less fat in those liver cells. So if you hear don't start them on it, please do start them on it. Start them on a statin. The next one is hypertriglyceridemia. So the goal there is less than 150. Again, with the lifestyle modifications, dietary modifications, increase activity, optimize glycemic control, and the statin can help to reduce triglycerides. Hypertension, the goal would be getting BP less than 140/90. If it's greater than 130/80 and there's diabetes, we want to put them on treatment a little bit sooner. And the RAS blockade is preferred if albuminuria is present or if the patient has ischemic heart disease or heart failure. So again, wanting to make sure all of these are under optimal control in order to control the fatty liver disease. The next one would be obesity. So again, even that 5% of weight loss will be a huge benefit to these patients in helping the liver disease. Again, looking at lifestyle modifications, adjunctive GLP-1s for those who would receive benefit, those who are have diabetes. And then the last one are diabetic patients. So we want the hemoglobin A1C to be less than 6.5, and we have several options to help them get there. We have SGLT2 inhibitors preferred in patients with heart disease, and then we have GLP-1s preferred for those patients who have heart disease and albuminuria. There are, again, the surgical considerations for patients who have obesity. Bariatric surgery is an important tool to meeting weight loss goals for certain patient populations, and they should be considered for the appropriate patients who need significant fibrosis, or have obesity and other comorbid conditions. Patients should be offered the options of bariatric surgery based on BMI and comorbidities. For those of a BMI of greater than or equal to 35, in the absence of comorbidities could be candidates, and then those who have a BMI of 30 to 34.9 with significant cardio and metabolic comorbidities could be candidates. Studies have demonstrated improvement in MASH and MASLD histology after bariatric surgery. So these studies were done 4, 6, and 8 months after bariatric surgery, and liver biopsies were done subsequently after that and did show improvement in fibrosis with the associated weight loss. So we're going to go back to our original case. This is a 57-year-old woman with type 2 diabetes and obesity, and she presents to established care at a new primary care clinic. She notes that she's concerned about dying from heart disease because this is what happened to her parents. Her medical history is significant for type 2 diabetes, obesity, hypothyroidism, osteoporosis, hypertension, and cardiovascular disease. Her labs include a hemoglobin A1C of 8.7, fasting triglycerides of 200, fasting glucose of 140. Her medications are metformin, glipizide, insulin, lisinopril, hydrochlorothiazide, levothyroxine, alendronate, and simvastatin. Her FIB-4 score is 1.5. Her liver stiffness measurement is 17 kPa, and her liver biopsy is positive for steatosis. So what interventions could you make to her treatment regimen to better address comorbidities and potentially MASH and MASLD? So a couple of things on this slide I just want to point out. So she has type 2 diabetes and she has obesity. So those are two underlying things that make me think that she does have MASH or MASLD. In addition, she did have a liver biopsy that showed steatosis. So just from those pieces alone, we can diagnose her with MASH and MASLD. We know that she has several things that are probably contributing to more severe disease. Her hemoglobin A1C is greater than 6.5, so that's elevated and telling me that that's out of control. Her triglycerides are greater than 150, so that concerns me that her triglycerides are out of control. And her fasting glucose should be closer to 90 to 100, and that is high and out of control. So we have a few things here that we probably should think about addressing. So addressing her diabetes medication, addressing her statin, seeing if a second agent or if there's room to increase the one agent would be beneficial. And then if you notice here, her fibrosis 4 score is 1.5. Remember to say that she doesn't have anything liver steatosis going on, it would need to be less than 1.3. So it is greater than that, and so we definitely want to work this up further, and they did by getting the liver stiffness measurement, which does show that she has some degree of fibrosis. Now, one thing I would be curious about is if her fibrosis score was in that 2 to 3 range, and we could use the Resdifra for management of that disease. So we would need to know what that staging was, but that would definitely be a consideration for her case. And again, we can't not, again, talk to her about the importance of dietary changes, lifestyle modifications, increasing in activity, in addition with some of the other medication therapeutic things that we would be doing for her. It would be really important to see her in close follow-up. My recommendation would be within a month, see how things are going, if she's had any weight changes, if her labs look any improved, and just have that close connection and build that patient rapport with her to let her know that she has a lot going on, but she's not alone in this scenario by any means. So here are a few takeaways. MASH and MASLD are common diseases with significant clinical consequences and patient burden. Collaborative, multidisciplinary approaches to managing MASLD and MASH is ideal when possible. In primary care settings, PCCs can successfully screen for, diagnose, and stratify risk for patients with MASLD and MASH. They can also treat less severe disease and refer to a specialist. Screening for MASLD involves identifying patients at risk, obtaining relevant patient history and laboratory tests, conducting non-invasive liver testing, and liver stiffness measurement to stratify risk. Treatment of MASLD and MASH involves improving liver and cardiometabolic health. Weight loss, resmetirom, GLP-1 RAs, and other treatments can help improve liver conditions. We hope you'll take advantage of this resource toolkit. Within it, you'll find links, helpful references, and a PDF of this deck and a recording of this presentation. Your QR code here is on the left, and that will take you to the link to the resource toolkit. And just let's recap and review what we've covered. We wanted you, from this presentation, that you would be able to take away and apply key evidence-based strategies for identifying and stratifying risk in patients at high risk for MASH. We want you to formulate strategies for diagnosing, staging, and monitoring MASLD and MASH with non-invasive tests and biomarkers. We want you to know how to implement current treatment guidelines and care pathways in managing MASH and MASLD and underlying metabolic diseases. And we want you to know when and how to initiate referrals to specialists for patients with high-risk disease, including MASH, as appropriate. To receive your certificate, please take the post-survey using the QR code or URL below. Thank you for your time.